First of all, congratulations on coming into the world of oncology and treating patients with cancer. It's a really exciting time to be involved. We have so many more things we can do for our patients. So pharmacology. These are just a few things. I'd like to really just take the opportunity to say there's lots of different treatments out there for our patients. It's a very exciting time, very overwhelming time for us as clinicians. But we have a lot more options for our patients, and there's a lot of information in these slide decks. I'm going to try to just kind of highlight what's important, but know that it's really hopefully meant to be a good reference for you. If anybody does have any questions at any time, you can stop me, or we can just wait till the end, whatever feels right at the time. But we are going to talk about cancer therapy. I like to use the stage, so I'm going to go over here. I actually dance, I tap dance, but I won't do that this morning for you guys. Do a little bit of Broadway. Okay. That is a past life, unfortunately. There's so many different kinds of therapies. There's chemo, hormone, immuno, all these targeted therapies. So I'm going to try to break them down for you as easy as possible, and try to also highlight what some of the common toxicities, and piggyback on our previous presentation as far as your assessment and what to look for, kind of highlight, hey, this drug, heads up, look for this. Okay? Simple and easy pharmacology. So before I get into the, there's going to be another talk for malignant heme. So there's a little bit of overlap with the malignant heme. You'll see a little bit of that integrated here. But I did want to take just a few minutes to say that benign hematology for anybody that's in the community-based setting is actually very important too. You're going to see a lot of patients that come in, they have abnormal labs, their PCPs are sending them, their anemia, they don't have enough iron, they have too much iron, they're having this, low platelet counts. You might see pregnant women that have low platelet counts, and clots are big. We see a lot of people that, they were in the hospital, they developed a clot. So just going to take a minute and kind of outline the benign heme, because I feel that there's value there for you. So chronic kidney disease is huge, especially in the older population, and the erythropoiesis stimulating agents really just help support what the kidney is already supposed to be doing. In iron deficiency, the most common cause of iron deficiency is blood loss. So if somebody comes in, you might see women that have heavy menses, or you may see nutritional deficiencies based on bypass surgeries, or just malabsorption issues with your Crohn's patients. So there is a role to give iron. So we do give quite a bit of IV iron. Different practices have different contracts as far as what they use. What I've tried to do in all of these slides is put generic names and brand names. That's just to help, because I have found that when I was new that it was super confusing trying to figure out what was what. But that's why you'll see first the generic and then the brand name. But I don't have any conflicts of interest related to any of the companies. On the other hand, we see people that have iron overload. Sometimes these are patients that have had lots and lots of blood transfusions in your MDS patients. So these meds are able to kind of help the body get rid of that excess iron. As we know, everything's a balance in life. Too much is not good, not enough is not good. So in the ITP world, what I've seen, we see women, they come in, they're pregnant, their platelets are low. What do we do with this? Or it's just idiopathic. We have no idea what causes it. So, basic corticosteroids sometimes really just change that outcome, and they resolve after delivery. But we do have IVIG and rituximab, and then we do have these other agents that help activate these receptors to make more of these platelet cells. So one is the oral agent, and again, I put in here if it's oral or sub-Q, because that might be a decision that's making, if you have a patient that's really compliant, that you know that they can take their pills, they're good with it, they might do well with oral. I like essential oils too. Sidebar on the brain. But if there's somebody that, needs a little bit more oversight, maybe a sub-Q would be better. There's lots of things that go into decision making. It could be insurance driven, it could be financial, it could be transportation. So that's, again, looking at the whole patient picture in driving decision making. We do a lot of anticoagulants. Some of the injections with the low molecular weight heparins, and what they do is they really inactivate the thrombin and the clotting factors to try to promote future clots from happening. I'm sure you've seen that there's more of these. These are injections, but there's more oral agents out there. Coumadin had been the traditional one, but it requires a lot of time and effort on people coming in, getting their INRs checked, dietary influences, as well as a lot of drug interactions. So some of these factor XA or 10A inhibitors have been really become popular. So that's kind of a little benign heme overview. Do you find that that was a little bit helpful, add a little bit of value? Okay. So we already talked a little bit about the cancer therapy goals. So I'm not going to belittle the point, but obviously you want to kind of identify, are we curing? What's our intent? Because that's going to drive our decision making, not just with what drugs we're going to use, but how aggressive we're going to be. If they're curative intent, we may push a little bit more. If they're metastatic, we might give a little bit more leeway. Our goal may be to control, or it may just be to comfort and keep the quality of life at a maximum. So when you think of treatment, someone told me this just this week. They thought about thinking about the body as being like a garden, like if we're a garden, and bear with me here. Cancer is like a weed, right? So a surgical treatment approach would be just to kind of take the weed out, right? Let's remove the weed. Now, we might hurt a little bit of the surrounding roots. We may leave a few roots behind, but we do the best we can to remove it. The radiation, I know I'm skipping over chemo, I'll come back to that, but the radiation is kind of like the sun magnified and treating and going and really trying to kill just that weed. But other things can be infected too. It's not perfect. Chemotherapy is like we're just showering the whole garden. We're just sprinkling the whole garden with everything. And we're getting the weeds, but we're also damaging good cells, good soil, right? Targeted therapy, again, still trying to round up. That's what I use. Spray the weeds. I just did this yesterday. I got to do it again. What is going on? You just spray the weeds, and you're just hoping that you get that part and leave it go. But immunotherapy is like sprinkling the soil and treating the underlying base of what promotes the garden growth. So just something to think about. Someone shared that with me, and I thought it was really interesting if you're thinking different ways about treatments. So Dr. Tan did talk a little bit about the treatment goals. I'm going to skip over that. So we have chemo, hormone, manipulating the hormones, immunotherapy with the soil, therapeutic antibodies kind of work. There's a lot of crossover, so it's not exactly simple. But we have combinations, these antibody drugs, where we have a couple combinations where we have a targeted therapy and a chemo drug that are together. And then these inhibitors, these targeted therapies, and then there's always some other ones that like to lie out there and be in their own world. Fatigue, these are just, I'm going to kind of go through. I have a couple more slides later, but fatigue is just across the board for patients. They can get post-op fatigue. They can have, fatigue, just psychosocial, mentally fatigue from all of the changes in their life and grieving the changes. All the chemo, everything, the different treatments can cause fatigue. So we don't have a lot we can do for that. So we usually just say, conserve your energy, do a little bit, take a break, do a little bit. If you feel good, don't overdo it. Patients like, oh my gosh, I felt so good. I got all my steroids and then I slept for 3 days. So they get excited when they feel good. So it's important to say, take advantage of it, but don't go overboard. The myelosuppression, that's like killing of the bone marrow cells, the red cells, the white cells, as far as those are the cells that get affected too, but we can manage them. There's things we can do. GI changes, mucositis, neuropathy. Again, I'll highlight a couple drugs that just, be on the way, on the lookout for. Not all the chemos, but most of them do cause some degree of alopecia. And then, of course, all the immunotherapy, you have to be watching for these immune-mediated side effects. So this is the body, like we're revving up the soil, but then we get a little bit overexcited sometimes, and we can get endocrinopathies, we can get issues in the liver, the enzymes can go up, you can get bad diarrhea, bad skin, and this can happen at any time. So even if they're on like cycle 8, cycle 9, you're not out of the woods. This can come on at any time. And then onc emergencies, Terry's going to talk about later, thank goodness. So just a couple, again, just things to think about why people wouldn't get treatment. They can't tolerate it. Sometimes there are some medications that have a lifetime dose. Adriamycin is one of them, which is doxorubicin, has a lifetime dose. Once you hit that dose, then you really don't want to exceed that. Some people do have really bad hypersensitivity reactions. The Taxols, the paclitaxel, docetaxel, people during infusions get back pain, or they get chest tightness, and sometimes you can stop it, do more meds, re-challenge, and they do okay, but other times there are people that just can't tolerate it. Another hypersensitivity, it would be carboplatin. This is something that number 6, if you write anything down, carbo number 6, they do good number 1, number 2, number 3, number 6, they get this bad reaction. For some reason, it's acquired. But that could be reducing that opportunity for that drug to help the patient. Resistance, and then if they have a secondary malignancy. Adherence is a big issue, and that's where you're doing patient assessment just to say, hey, listen, being in the medical field, being a clinician, it's an art and a science. So the art is really getting to know your patients and tailoring your conversations and your care to that particular person. Insurance is a huge problem. I'm sure you have already seen that. They'll only pay for this or that, or the cost is also an issue. So just keep all those things in mind. Okay, chemotherapy, messy. Okay, so we're just using chemicals to treat cells, right? So previously, she was, talking about the DNA and how things are mixed up. So what we're trying to do is we're trying to get in there and trick it up. Even though it's already messed up, we're trying to trick up the DNA to try to kill the cells. Oftentimes, more than often, you're going to see all these different combinations, not just combinations of chemo use, but you're going to see like chemo and immunotherapy. That's like first line now in some treatments. So we're kind of going in all these different ways to do whatever we can to maximize the benefit, but not kill the patient. Okay, we want to make sure the patient stays alive or it defeats the purpose. The other thing is just to know if they're doing it, neoadjuvant is more common these days, so we're doing it pre-surgery, trying to eradicate disease as much as possible so that we don't have to have as invasive of a surgery, versus after surgery, more like the insurance policy, make sure there's nothing floating around, and then there's metastatic is just chronic management. Are you guys okay? Are you bored? No? Okay. I took a few things out. I used to have like the cell cycle. I could take that out. You don't need that. You guys know, I always say I like pathophys so much I took it twice. It's true. My parents weren't happy. I'm like, I went to every single class. I took my tests. But it was too much. Anyway, so true, the best way to learn is to teach. It really does make a difference. So this is just a quick overview of that, these cells, a lot of these chemotherapy drugs, they work at cells like during a certain phase. Some are specific, some are not. Okay, this is how many classifications there are of chemotherapy. That's a lot. That's a class. That's not a drug. There's like drugs in all these classes. So that's why I prefaced it earlier that you know, I'm going to put things up here and use it as a reference. You're not going to know everything. I mean, you have guidelines, the NCCN guidelines are out there. Find a mentor. I think it's important. Find somebody that you connect with, that you feel comfortable with, that you can talk to. It might be your physician. It might be a peer, an APP. It might be an infusion nurse. I was an infusion nurse for 8 years before I became a nurse practitioner, and found that to be incredibly helpful because the infusion nurses, they know the drugs, they know how they're given, they know the reactions, you know, they know a lot. So make friends, and they will help you. So basically, this is just a generic kind of alkylating agents. They interfere with this DNA. So that, you know, they try to break the DNA stranding. That way they can just kind of kill that cell. That way that cell can't make more bad cells, okay? Many are cell cycle nonspecific. These just FYI pharmacology that they're cytochrome P450. So it's really important, guys, that you know what other medications that these patients are on. I've got medical assistants. They come in. Some are good, some are not good, some are consistent, some are not. I go through their meds with them every single time, and I have my peers like, I don't have time for that. Well, guess what? I don't have time for harming a patient. So I make an effort when I see a patient, you know, and I mean, if you're seeing them every single week, but take the time to know what meds they're on, and be sure you ask them, are you taking vitamins, are you taking herbs? Because they don't think of them as medications, or even over-the-counter meds. They don't think of that sometimes. Okay, so nausea, vomiting, the bone marrow suppression. Just be mindful in your patients that are younger and could be in a reproductive state. It might be, depending on where you're working, that you want to make sure they're not pregnant, make sure they're not lying, take a pregnancy test on them, because they might say, I'm good, because they want to get their chemo, because sometimes they don't want to tell you what's really going on. And, you know, you can also talk to some people on the, you know, ask them if they're interested in any kind of, you know, banking, egg banking, sperm banking. There's lots of different resources for people when they're young. Because I have a young Hodgkin's patient right now, and she's 23 years old. She just graduated from UF with her degree in zoology. So, you know, she's young, and you can't forget to talk to these people. Not all our patients are, you know, older adults. Okay, so these are all these different drugs, some of them. Let's see, the main ones that I can pick out. So, okay, CML is for, does everybody know what these, like HL is Hodgkin's lymphoma, NHL is not National Hockey League, it's non-Hodgkin's lymphoma. Everybody okay? Or MM is multiple myeloma, okay? I just don't want to take for granted that people know what I'm talking about, but it's a lot to write them out every single time. So we don't use, well, bendamustine we do use. Does that anybody know? Did anybody know that the nitrogen mustard was the first chemotherapy agent that was out there? Okay. Gosh, people are smart. That's good. I had to be in it a long time before I knew that. The cyclophosphamide is very common. We do use that in quite a few regimens. That can be given, mostly you'll see it IV, but it can be PO too. So just FYI with that. And that's one, sometimes people can get like sinus pressure during their infusion. I haven't seen it in a while, but just FYI. Okay. So the nitrous ureas, excuse me, I guess I need more coffee too. The carmustine does, not everything crosses the blood-brain barrier, okay? So just be aware that not everything does. Again, these aren't drugs I see a whole lot of. Some of these are older agents. Now cisplatin, remember Jessica was talking about the ringing in the ears. If they're on a cisplatin regimen, they might be getting weekly cis with radiation. They might be getting every 3 weeks. So just know that's one, if they're on that drug, ask about their hearing. The carboplatin, we talked about the fact that that could be a hypersensitivity reaction like number 6 or greater. It may not be at 6, but don't think if you get to 7 that you're out of the woods. And then oxaliplatin. Oxaliplatin is unique in the sense that it can cause, people can have to be really conscientious about having any contact with anything cold. Are you guys aware about that or have a little bit of knowledge about that? I had a patient when I lived in Philly, and she's getting her whatever regimen FOLFOX, and she goes and I have to go to the bathroom. So she goes to the bathroom and she sits on the cold toilet in the middle of the winter and has a laryngeal spasm from her oxaliplatin. She was fine. But I feel like we don't have to worry as much. Like up north when I worked there, it was like scarves, and we had to really talk to people about that. But people can, I've seen some bad oxaliplatin reactions too, usually down the road. But when you've got people that have, maybe they got their 12 cycles in the adjuvant setting, now they're in a metastatic setting and they're at like number 20, just be on the lookout that they can react to. Okay. The antimetabolites, again, these are all inhibiting DNA and just trying to trick up the bad cell. Okay. All right. So methotrexate, anybody know what color that is? Yellow. There's only a few that have a color. Fun with that, but I worked in a sarcoma center, and we did high-dose methotrexate. Again, not a drug we use a whole lot of, but you may see it. The Alimta is pretty common in these folate antagonists, and you're going to see that with the non-small cell in the lung. With the Alimta, and I call it Alimta because it's easier for me to say, just FYI, people need to be on folic acid during that. It's a folate antagonist. They can deplete their folic acid levels, so they should be on that, and they're also getting B12 injections. Those should be built in the regimens. Okay. So Jessica was talking about hand-foot syndrome. So capecitabine, which is Xeloda, that's an oral agent, and basically that's one that can cause a lot of hand-foot syndrome. So you definitely make them take their shoes off. I know it might be nasty to ask them to take their, depending on the patient. If they have a family member, maybe they can help, but really look at their feet because it's something that if you get on top of it on the front end, it really makes a difference in the long run for them. And 5-FU was one of the first chemotherapy agents that's been around for a really long time, 5-fluorouracil, and we use that a lot in the combinations. More by itself is mild as far as nausea and vomiting, but I haven't seen it used in a long time with just like a weekly 5-FU leucovorin combination. So gemcitabine, this is the one drug that can really affect the platelets. So, we're looking at the white count a lot. We know the hemoglobins kind of trend down over time, but the gemcitabine can really cause the thrombocytopenia, so just be on the lookout for that. Gemzar can also cause a fever. So they go home that night and they've got a random fever, but they've got no other infectious symptoms. Gemzar can cause that. I've also seen some pretty bad rashes. When Jessica was showing some pictures, Gemzar is one of these drugs. We can see one of those like generalized drug rashes. Okay. So these are the taxanes, and the big thing with these are the peripheral neuropathies, and this is important, and I'll go back and mention with the oxaliplatin also. The peripheral neuropathies are just one side effect you want to be super careful about because it can affect these nerve endings that it could be permanent. So a lot of these other side effects, you take the treatment away, their hair grows back, their mouth sores get better, their bowels re-regulate, but this peripheral neuropathy can be, it can even continue to get worse. So please, like anybody that's on a taxane, Taxol, even Abraxane, all these medications can cause peripheral neuropathy. I had one guy I took care of a few years ago. He had gotten oxaliplatin when it was kind of newer and we didn't know. He couldn't walk. His peripheral neuropathy was so bad. But we didn't know then at the time that it wasn't going to get better. Okay, the vinca alkaloids, these can cause some neuropathy as well. And again, it's just so important that you talk to your patients and take the time, and you might have to pull it out of them, but you know, what do we do? Do we hold the drug? Do we dose reduce? Do we just skip this particular cycle? I mean, there's lots of different things that can be done. My favorite one to say, Dr. Tan, help please. I can't say it ever. Topo, which is, anyway, we see these, we use, you know, there's just something she just can't, I can't get past it. It's, yeah, whatever. Topo, we'll just call them Topo for short, if that's okay with you guys. Okay, so these also are interfering with DNA replication, okay? We use irinotecan quite a lot in the colorectal. There's irinotecan liposome that's out now that is actually a good option for people for metastatic pancreatic. Again, don't have an abundance of options for those patients, so this is something else that can be particularly helpful. And the topotecan we see with the, again, that's why topo's easy, topotecan. Anyway, we see those you know, in the ovarian, kind of at the end of the, you know, we've already exhausted other options. So these are the topo 2s, just call them that. And this is actually another colorful one, novantrone. We used to call it tidy bowl because it's blue. So don't see that a lot. I haven't seen that in a long time. But again, this is just an overview. It's out there. Okay. These anthracyclines, does anybody have any questions, or you guys okay? Brains fried?
So we'll ask them a question.
Okay.
So what have you learned so far? Write it down. One thing. So let me give you a clue. What Lindsay is teaching here is too confusing for me. Very important thing, no, you are a good teacher. Very important thing for you to remember is actually to recognize how you learn. Did that sink into your brain? How you learn. Some people learn by memorizing all this, I don't. Some people actually learn by seeing patients and looking at the drug. Some people learn by looking at pictures. If we're talking about microtubules, we're talking about structure. You see, this building has structure, and there are certain things that basically promote growth. By disturbing the microtubule, which is a structure, meaning this structure, the beams that support this building, we destroy the cancer cell. So that's sometimes a way of understanding how chemo works. That way, I understand buildings. I know what buildings are. But when you recognize that, then it's easier to learn. So it's overwhelming, but you can put it into bits and pieces so that you can remember it. Go.
Okay.
One other clue. If you have a patient with ITP, how do you differentiate it from DTP? Very simple. Look at your patient. Look at your patient. If their platelet is 20,000, what does look good mean? They look well, they're talking to you, they had a viral infection 50% of the time. That's ITP. That patient is well and doing and good. If they look horrible, you might say, what's horrible? They're actually tachycardic, hypotensive, have a rapid pulse, they're thrombocytopenic. You look at the slide, they have microangiopathic hemolytic anemia, that's a strange word, but their LDH goes up. They look at the slide, you look and there's a lot of schistocytes, that's DTP. Ladies and gentlemen, very important. call your blood bank. That patient needs plasmapheresis. So those are kind of little bits. She was talking about that. But with ITP, you just can say, let's relax, take a pill, prednisone, you'll be okay. Well, by the way, that's not true. 50% of the time, they will go into the chronic phase of ITP. But just put what you know into practice, try to visualize it in a different way, and try to recognize patterns. Lindsay.
Okay. So back to my boring presentation of memorization. No, I'm trying to give you things along the way. But so the anthracyclines, these are the ones that have a lifetime dose, the doxorubicin. They can have some long-term cardiac effects. So this is somebody that you want to get a baseline ejection fraction on. It can be done through an echocardiogram, or it can be done through a MUGA scan. Usually it's a preference of the clinician, the team. And the liposomal doxorubicin, which is the Doxil, that's another one that you can get the hand-foot syndrome with, okay? So these are people, we tell them not to wear tight clothes, and you really want to look at their hands. Some people, they think if they put their feet in their hands in ice, I don't know if anyone's seen this, some places they do it, but they think if they like vasoconstrict, they won't get the drug to that area, and then they will not get the symptoms. So you may see some places do it, some places don't, but the hand-foot syndrome is common. The epirubicin and idarubicin are more common in Europe. And the etoposide is another drug we use in small cell. This can drop your blood pressure. So this is something where post-treatment, your nurses should check their blood pressure, make sure they're doing okay. Okay. So if you kind of see the theme here is mess up the DNA, where the DNA has been disrupted, things have been changed. That's what into this cancer cell, so that it has beat the system of the body recognizing that it's a bad cell, so it continues to live and grow. And these are just all different ways that we're trying to disrupt the function of the cell. So these are another, these mycins. The bleomycin is actually in a regimen. I learned recently that when you have Hodgkin's, this lady, I'm telling you, this young lady, the zoologist or whatever, she was, she gets ABVD, adriamycin, bleomycin, vinblastine, and dacarbazine. Those are the bleo is actually, we don't give the Neulasta, the growth factors in that, because there's some evidence that the growth factor support can cause more pulmonary fibrosis and lung problems. So with the bleo, they do have to get a baseline pulmonary function test. But that may be a drug that we don't see as much going forward. Mitomycin is the other one that has a color. It's my favorite color. Does anyone know what color it is? Purple. Yeah. It's a good, strong color. Color of royalty. All right. So these derivatives, same thing, just working a little bit differently to kill the cell. And again, we don't see these that often in the outpatient setting. This is going to try in a way to restore normal tumor suppressor gene function and control the cell differentiation. And we use this in the MDS population. Of note, the MDS population is a special population. So when you're treating solid tumors and you have patients that are getting chemo, and if their white counts are low and their hemoglobin's low and their platelets are low, you would probably hold their treatment because you don't want to make them go lower. But in this MDS population, this is a situation where you still treat the patients even when they're very low because their bone marrow is not working. Okay, and here's some other therapy agents that we use. The octreotide we use, this is more, it kind of manipulates hormones, glucagon. This is something we use in neuroendocrine tumors. Okay, enough of chemo. But at least the good thing is we have a lot of options for our patients. And the common theme with the chemo, if you think chemo, think you're sprinkling the whole garden and that there's good stuff going on, but there are a lot of side effects and toxicities and that people need to have a good performance status. So in hormonal therapy, what we're trying to do is we're trying to take cancers that are hormone driven and we're trying to block those processes. So what we're trying to do is basically in estrogen blocking, get the estrogen down. If it's prostate, we're trying to get the testosterone level down. And it's just if you think about like what happens when women go through menopause and they lose their estrogen. They get tired, they get hot flashes, they get moody, their bones get brittle faster, their weight changes. So if you think about it, like Dr. Tan's saying, like think about it, it makes sense. So it will help you remember. And men can get the hot flashes, the fatigue, they can get impotence, the osteoporosis, so very similar, but they can actually, get gynecomastia, which is they can develop breast tissue. So if somebody comes in, a man, and he's like, something's going on, think about what the diagnosis is and what medication they're on. So these are the different kinds of hormone therapies. Not going to spend a lot of time on them. Again, I just want you to kind of have it as a reference. Bless you. We do use the Casodex. I have a patient on that right now. We are using the Xtandi. These are medications that, again, they manipulate the hormones. Where are you? These are oral agents. So again, think about your patient. Are they, good with taking pills? Do they have a good support system? These are the aromatase inhibitors are very common in breast. These are postmenopausal, okay? So these people, because the way they work is if women still have their ovaries and they're producing estrogen, then these aromatase inhibitors don't work. So postmenopausal is a key here. Also, the patient has to have ER/PR positive disease. So if their breast cancer is not receptive or driven by estrogen or progesterone, then these aren't an option because you're not going to get a benefit from it. Does that make sense? So this kind of can cause all those symptoms we talked about. People can get kind of like joint pain, they get vaginal dryness, accelerated bone loss. So we're checking bone densities on these patients, standards every 2 years. So we usually get a baseline and see where they're at so that we can monitor them. These are the 3 that are on the market, the aromatase inhibitors. Okay? So this is the injection that we use. That mechanism is different. It downregulates the estrogen receptor. Again, the ultimate goal is to try to reduce estrogen in the body, which is driving a bad cell. This drug is thick, and not that you would be giving it, but just FYI, just be sensitive to the patient that it's usually in 2 injections, and that it can hurt the patient. Like initially, it's thick. Most patients are fine with it. They know that the benefit outweighs the risk, but just an FYI. And then we have tamoxifen. Now these are good with your premenopausal because it's just kind of binding to the estrogen that's already made. The aromatase inhibitors is kind of inhibiting the process of the body taking what's already in the body and transforming it into estrogen, as is just kind of a simple explanation. But these people that are on the tamoxifen, they really do need a baseline GYN exam because it can cause some changes in the uterine lining. So you want to make sure. And this could be a person that's postmenopausal and they did an aromatase inhibitor and they failed it because it didn't work for them. So then they're on the tamoxifen now. But if they have their uterus and everything, they really still need a baseline GYN as well as frequent exams. Okay. So this is working on the testosterone, which drives the prostate cancers. So have you seen these meds before? Okay. So these can be given, they can be given every 3 months, they can be given every 6 months. There's different scenarios, but they are injections. That's another injection. So I'm just going to keep going because there's a lot of stuff here. And these are some other hormonal. The Zytiga is that's an oral agent that is, it basically works to try to decrease the sensitivity of the tumor with the testosterone. Okay. Hormone therapies. Anybody have any questions? It's sort of basic. You're blocking hormones. Your hormones are what's driving. Okay. So immunotherapy is really the big thing right now. It's very exciting for people that have been around for a while because there's finally data and it's really doing a lot of good for patients. So we're really just trying to sprinkle the soil, let the body try to do what it's designed to do, if you think about it. So we're going to modify this environment between the tumor, the weeds, and the garden. Okay, and we're going to use it in different ways, antibodies, cytokines. It's complicated, right? Okay, so interferons. I actually just had a patient this week who was on pegylated interferon for like stage 2 melanoma, and wow, it reminded me, that poor man, he got one injection 4 hours later. I mean, he had flu-like symptoms, tired, but this is all we used to have for people in some of these settings. But now we have the ipilimumab, which binds to the CTLA-4, and it blocks this T-cell activation. And that's been very successful in the melanoma population. In fact, now we're not only are we combining like chemos and targeted, we're combining immunotherapies as well. So nivolumab, I'm sure you've seen commercials. Every time, I don't watch that much TV, but when you turn the TV on, do you see commercials? So they just got a new indication too. I mean, they're getting, and it doesn't matter if they have the PD-1 testing or not in some cases, but it started with melanoma and renal cell, head and neck. I have patients, urothelial, this MSI is really been defined, and I believe the rep that was in on Wednesday said the newest indication was in hepatic cell carcinoma, HCC. Yeah, so that just came, it wasn't even on the updated prescribing information. So a lot of exciting things for lots of different patient populations. Some of these populations haven't had any advancement in a long time. Okay, I'm going to move again. I see some people nodding. I'm like, okay, what do I need to do? Okay, so the Pembro, which is easier to say than pembrolizumab, Keytruda, it's a very common. We have a lot of patients on that. This indication has expanded quite a bit too. And some of the data that's coming out is saying, it may not be superior in overall survivor per se. I'm just making a general statement, but it's a lot more tolerable for patients. So they're looking at that. And again, it's a lot of information here, but the fact that we have these options for patients is a really big deal. Anybody familiar with Provenge in the prostate cancer first-line metastatic setting? They do like an apheresis of their, and then they give it back to them, and for a very small patient population can be a really good option for them. But that's all working on the immune system as well. So they're working on the T cells. Okay, so here's the interferon. This is how it works. It activates the natural killer cells to enhance the immune response. Let's just keep going. Dr. Chan, have you used the interleukins in a while?
Not recently.
Yeah, I haven't. I have them in here because I think it's good to know of them, that they're there, but I haven't. I just wondered if you had seen them or not.
I actually spotted it many years ago.
Oh, on interleukin. So this is the other part. I kind of put this on the other immunotherapy, but this is really, these colonizing stimulating factors are really help. This is more supportive care. So when the white count goes low or the red cells are low, this can help stimulate the body to make more white cells, make more good cells. And these are all the ones that are on the market for them. We talked a little bit about the erythropoietin and like chronic kidney disease, but there is a place for it with chemo-induced anemia. Okay, so targeted therapies, try to give you some kind of visual here. Cut off, these are the way they work. They cut off the blood flow, or they target a specific cell, or they carry a drug to the tumor. They could be a carrier, or they just cause death, the apoptosis, or they can make the cells more sensitive and receptive to other, there's like a synergistic type of response, or they just cut off the lifeline, they block the signal. So these are antibodies, these therapeutic antibodies. This is considered passive immunotherapy. They usually end in the MABs, might help. Some of them are mice driven. Some of them are human and human. So there's different ways that these are actually driven. Some are human and mouse. And some are conjugated. They're put on a radioactive piece. Common targets. So again, this is where all the testing that Jessica was talking about, all like the molecular testing is really important, because we need to know if they have these different receptors, because if the drug we're giving is targeting the receptor and they don't have the receptor, then we don't give the drug. So rituximab and ofatumumab is not as common. Things are changing every single day, but these all go after CD20. And then we have EGFR, and these are the cetuximab has been around for a while. These are the drugs that the different tumor types, rather, that the colorectal and the head and neck that we use them in. The EGFRs can cause rash. They can cause like an acneiform rash. So sometimes patients are on some type of like a tetracycline, like doxycycline, 100 milligrams twice a day, something like that to keep the rash under control. It literally looks like an acne rash. Or they can use some kind of topical, like a Cleocin or some type of topical to help manage that. The panitumumab, which is the Vectibix also, just that class can cause a rash. In the HER2 realm, the one thing we do follow is ejection fraction. There can be cardiotoxicity there. So we do, while patients are on, we do a baseline ejection fraction, echo or MUGA, whatever is the preference, and every 3 months while the patient's on treatment. And then when they complete treatment, if it's adjuvant, every 6 months up to 2 years. So a lot of monitoring of the heart there. Okay. I put what these different acronyms mean. I can't begin to say them, to be honest with you, which is why I think they're acronyms, but I hope it's helpful. It was learning for me to know that it does stand for something. We do use the XGEVA here. So we talked about the patient that maybe has bone mets on presentation, or we do use it in hypercalcemia too. So one of the onc emergencies that Terry's going to talk about, I think, is hypercalcemia. And I had a patient that just be sure that again, too much, not enough. So we might give it because it's hypercalcemia, but let's just say we have a normal patient that their calcium level's normal. When they're taking these meds, they need to take a supplemental calcium, because I had one patient, he got so hypocalcemic, he was in the hospital for quite a bit. I mean, his calcium was 6, and his neurological, he really had a lot of issues. So it's just pay attention to those levels when they're on that medication. And then these VEGF, the vascular endothelial growth factors, this is one where they are inhibiting blood flow. So let's just say you have a patient that's on the bevacizumab and they need to have a surgery, they have to have a dental extraction, something like that. Be aware that, or they have a wound, if they've developed a wound, that's something that you need to hold that medication to help promote healing in that setting. Now, obviously, if it's an emergency, they get in a car accident or something, they're going to do what they need to do. But ideally, you want to be asking them, are you having any procedures coming up or anything going on? Most commonly, it's dental work, but it could be like a hernia repair or something like that. So these are different. These are the conjugates where we do the combination, where we talked about. These are enzyme inhibitors. Gosh, we're almost done. We still have 20 minutes. You guys all right? Okay. Here, I'd like to just show you, look, 2001, I remember when imatinib came out, and we're like, oh, what's this? And now look how, this thing only even goes to 2015. We have more stuff now, but you can see how much development we've had. And these are all, again, they're targeted, and this is the target that they're trying to do is the BCR-ABL for the 3 that are on the CML. People tolerate them pretty well. They can get some nausea. It's really just about talking to your patient. And let's see, on the ALK positive patient, the ALK-ROS positive, non-small cell, they're really small patient population. So, but with that patient population, really good option for them. BRAF is very big with the melanomas. That started about 2011 or so that we started having all these options, and they are oral agents. So, and let's see, the BTK, the CLL, some of that's malignant, that they're going to talk about a little bit more, but I got a patient on the Imbruvica 3 years. 3 years has held this person's disease stable. So really good things. And we have the Ibrance. Again, these are just kind of connecting which inhibitors. The Ibrance, you do need to monitor their blood counts. And you know what? All this is in the package insert, the prescribing information. That should really be your best go-to, because when you go in there, it tells the mechanism, it gives all the side effects, the percentages, it gives the indications, everything's right there. And these are some more of the EGFRs. Again, these can cause some bad rashes, some acneiform rashes. The BCL2. This is relatively new, but these are people that failed the Imbruvica, and they have to specifically have the 17p deletion. So again, all these details about the patient, like everything they're telling you, but even their pathology, all their genetic testing, all the, whether you use neogenomics or whatever you use, it's really important because that's going to drive all the decision making. Trying to think if there's anything else to piggyback on. Just a lot of these are oral agents, so you have to see how your patient's performance status is. It'll tell you how to dose reduce. Oftentimes we start out with the dose and we do end up dose reducing, but it really just depends on the patient and how they're doing. The MEK inhibitors, again, that's in the melanoma population, and then the mTOR is the everolimus is that's made a lot of headway in helping our patients. So I like this slide because it has a little bit of overview of what the toxicities are, things to look for with the VEGF versus the MET, the HER2, the ALK, the JAK, the BCR-ABL. It really gives you some things to look forward. So something like that's probably like when you're compartmentalizing to think about these different drugs and different options for the patients, then I think something like this is helpful. PARP, proteasome, we have all these other inhibitors, and it's a lot. Did you guys know there was so much? You knew there was a lot. It always surprises me, even when I go back and I review all these medications, and I think, oh wow, because you get to know, like in your practice, where are most of you, what setting are most of you practicing in? Community? Yeah. It's hard to be in community oncology because it's a lot of moving pieces. So all of our patients are going to need support. Things we can do for them to help support any of these kinds of side effects that they're having. They could get IV hydration if they're dehydrated. Taste changes could be an issue. If their electrolytes are low, we can replace them. We have really good antiemetics. I mean, one of the biggest things that patients are scared of still is throwing up and nausea. And I can't tell you how many patients now are pleasantly surprised, like, oh, my stomach hurt a little bit. But these are regimens where people were throwing up and, I mean, really having a tough time. Good antidiarrheals, good new stuff coming out all the time to keep people's bowels moving. Nutrition is so important. I have so many patients, oh my gosh, I'm gonna lose weight. I don't know if they come to you or you're seeing that, but they come and they say, oh, I really wanna lose weight. So now's not the time to lose weight. Your body needs nutrition. And we do have appetite stimulants that we can use for the patient. And then antidepressants and anti-anxiety. So these are, when I say supportive care, some could be pills, but some could be lifestyle changes. Some could be counseling, not just for the patient, but their family too. I had a caregiver the other day. He goes, I need help. His wife is driving. She's breast, and she's just anxious, and he just doesn't know what to do with her. And that's getting to him, he was shaking. So it's important to kind of know what services you have in your area to help people. So don't forget Dr. Google. Just remind your patients to be careful about the internet because it's a lot of good information, but a lot of misinformation. It's not regulated. A couple last thoughts on this is just try to stay up to date as much as you can. I actually, ASCO has a daily email called the post-ASCO update. I don't think that's really what it's called, but if you go on their website, I get an email every day with all the updates. So even if you don't get to read them every day, you could go back and take a look at them, and they'll tell you if there's a new indication or a new change. It's something that you don't have to go to it. It will come to you. So just know that there's things changing all the time, and know that it's okay to not know all the answers. And if your patients ask you, I'd say that, what, I'm not sure, but I'm going to find out. I'm going to find out where we can get the information for you. Things are changing. So I think just having that human factor with them and being honest and saying, I don't have all the answers, but I do know the resources. And, I don't know exactly how this is going to, everybody's different. I can tell you what my experience has been or what the literature shows, but we're going to get through this together. So, and encourage them to tell you what's really going on, because people will withhold information because they want to get their treatment. They want to get it over with, for whatever reason. But it's so important that I make it about it's safe. We want it to be safe for you, because if we treat, well, my platelets are 60. Well, if we give you chemo today, then they're going to drop and you could bleed and it could delay more treatment. And, just talk to them and help them understand that even though it might feel like the right thing in the short term, the long term is not necessarily going to be beneficial to them. Use your other disciplines. It's a little hard in the community setting. We don't have all the support as they do in the academic setting. but maybe, try to find, if there are some people out there, whatever it is for them that makes, therapists, or even if, what we say a lot is what's on your plan. See who's in your plan, your health insurance plan, and then we can guide them from there. And this is just, spend time with other team members, get to know, we are all a team, everybody from the schedulers to the people that, your MAs, your phlebotomists, your lab people, we're all working together, and, we're all in it together. So I always say we can all either work together and help each other out, or work against each other, and it's already hard enough to be in a setting like this all the time. There's a lot of good outcomes, but it's tough. That's my favorite thing. Together, everyone achieves more. I'm from Hershey, Pennsylvania, the sweetest place on earth. And I used to work at Hershey Park, and I won't sing the Hershey chocolate song for you, because you've already had enough with this. But I remember learning this. I'm like 16 years old in my first job. Together, everyone achieves more. I'm like, what is going on? It was like you had to have a guest service training every year. But I really learned a lot from that job, and how to treat people and listen to people. And we are a team. Not just here, like professionally, but even in your personal life. We're all kind of in this together. So Patch Adams will leave you with, he says, you treat a disease, you win, you lose. You treat a person, I guarantee you'll win no matter what the outcome. So our job is improving the quality of life, not just delaying death. So I'll just leave you with that. And thank you for your time. I hope you found this to be helpful and valuable, and if you have any questions, I'll be around later. Okay?